Thank you so much for being here today. We're very excited to bring you this webinar about leveraging DataDirect for mental health research to everyone. And we figured what better time to offer this than during the month of May, which you might know is Mental Health Awareness Month. I'm Meghan Seewald, manager of the Data and Design Core at the Eisenberg Family Depression Center. I'm joined by two lovely co-panelists, Erin and Emily. Do you want to introduce yourselves briefly?
Go ahead, Erin.
Hi, welcome everyone. I'm so thrilled to be here today, and I am the director of the Data Office for Clinical and Translational Research, which is a unit in the medical school's Office of Research. So one of the things we offer are self-serve tools, which Emily will dive into today, but I'll talk about some of our other offerings and services during the presentation.
And I am Emily Urban-Wojcik. I am the statistician lead at the Data and Design Core in the Eisenberg Family Depression Center. And I'm excited to take you through some tools and kind of a use case and what I've learned about DataDirect.
Awesome. You can go to the next slide. So to set the stage for this webinar today, I'm going to start by sharing a very brief overview of what we do within the Data and Design Core and how we've used DataDirect within our work. Erin, we're so excited to have Erin with us today. She's going to share a high-level overview of the DataDirect tool and what else is available from her team and how you can use this tool for mental health research and what exactly it covers, what data are available. And then the bulk of our time today is going to be covered by Emily, who's going to offer a tutorial for exactly how to use DataDirect within your research. So this includes gaining access to DataDirect, identifying cohorts, identifying variables to download or what's called output views, cleaning data and analysis. So she's going to walk us through step by step how to use this tool and share some very valuable tips and tricks that she's picked up from her experience. So if you've used this tool in your research before, we hope that you'll gain some new tips that might help you use it more efficiently in your work. If you've never used DataDirect before and you just, maybe you're interested in doing so or just want to learn more about it, this is going to offer you that hands-on look at how to get started. I want to mention that the session is being recorded and we'll send out the recording afterward. We also have a written step-by-step tutorial and some example code that we'll share. So you'll have many things to refer back to. You don't feel like you need to take notes during everything that we're saying. Next slide, please. So I wanted to start by sharing a bit more about our team and our goals, which will shed some light on how we came to start working with DataDirect and what we think the value is. Our team within the Data and Design Core, our bottom line is that we want more people to be using secondary data sources for mental health research. So pretty much everything that we do is rooted in optimizing secondary data. Specifically, we want to leverage existing secondary data so that we can generate impactful research findings more quickly and efficiently and support the career development of promising emerging scholars. So we see secondary data as a tool both for research advancement and career advancement. Next slide, please. If you are new to secondary data and you're not sure what that means, secondary data is just data that you've not collected yourself to answer a specific research question, but rather the data's already been collected by someone else or some other institution, usually for a much broader purpose. For our team, this can take generally one of two forms. So we're either referring to data from a large national survey, usually either nationally representative or longitudinal, on a very broad topic with lots of different measures, and there's many examples of those types. But we also use this term to refer to clinical administrative data, such as U of M's DataDirect tool, which is what we're going to spend our time talking about today. Next slide. Our team has found DataDirect to be a hugely valuable tool for advancing mental health research. And while our focus today in this webinar is on mental health because that is the focus of our team, the lessons and tips that we'll be sharing are also relevant for other topics and other health conditions that you might be interested in studying. So for those who may not know, DataDirect is a web-based self-service tool which pulls Michigan medicine patient data from MyChart into a usable research database. We're going to get into a ton more detail throughout the session today, but it allows researchers to examine relationships between mental health and many other physical health conditions and health service utilization. Emily's become somewhat of a super user of this tool, so we're excited that she'll be able to share more about her experiences today. But our team has used DataDirect for a number of different projects, including looking at things like centralized pain, cancer treatment, diabetic complications, all in relationship to mental health. There is a ton of data available within this tool, very large sample sizes, and it's free for those with a U of M affiliation to use. So it's an incredible resource. We're excited to share more about it and for more people to learn about it. And with that, I'll pass it to Erin to share more about the tool.
Thanks, Megan. So I think one of the reasons I'm most excited about today is when I think about mental health, if you're as ancient as I am, you might remember a day when there was a physical health record for a patient, and then there was a psychiatric health record, and they were separate health records. They had different access. They were physically separate when it was paper, but even when the early electronic health records started to be implemented, psychiatry was still thought to be its own, record with a wall around it. And what we now appreciate about mental health is that it's rarely just one mental health issue without other comorbid conditions, without other social conditions, without other demographic considerations, that mental health is best addressed and studied and treated as a whole patient. And so I'm grateful not just to look at, to be pulling data from the electronic record, which now has, mental health, physical health. But what I want to talk about a little bit today is some of the other types of data that we're able to access. And this is I have the easiest role on this webinar because Emily and Megan go so deep into the tool. I get to just tell you about what's coming. So Emily, if you'll go to the next slide. So, we keep evolving what our tools are and what our services are because the need from you all in the research community also is evolving. So, we used to be happy with paper medical records and just handwriting or entering into an Excel spreadsheet and then analyzing from there. We now are moving toward, I'd say we're between the third and fourth figures here, in that we're really moving into a more sophisticated digestion of data, linkage of data across very different sets. So soon we can actually convert that into information to better understand and treat people, especially with mental illness. Next slide. So the early years of the data office were really just trying to harness that electronic health record data. We had a couple of different products that preceded Epic, and then in 2012 and 2014, Epic was implemented throughout the health system. So we tried to get just all that structured data, diagnosis, labs, all of those kind of low-hanging fruit, and quickly began to see that would give us a little bit of the secondary data that Megan just talked about to look at patient to do patient research. However, we quickly needed what are the genetic underpinnings of health and wellness? How about social? What's the environment in which the patient lives? What does their social support look like? What does their neighborhood look like? What kind of climate do they live in? What are their other physical comorbid issues? And so we began to say, you all have needed this for a long time. How can we have our tools and our resources meet your evolving data needs? Next slide, please. So today, the first two types of data at the top, medical phenotype and genotypes, we're getting pretty good at. Again, the medical data is largely structured. We have a complementary tool to DataDirect called eMERS that I'll talk about in a minute that's unstructured data. And then there's over 100,000 patients at Michigan Medicine who have consented to have their DNA genotyped, so that you're able to look at what are the outward-facing clinical characteristics and what are the genetic characteristics. Behavioral and lifestyle data, I think of as a lot of information about the patient's activity, sleep, mood, heart rate, things like that, that wearables. Think about the Apple Watch, the Fitbit, other biosensors at home are able to augment the clinical data that we have here at the health system. So those data are beginning to come in. Environmental data, I mean, being at the University of Michigan, we have schools like the School of Environment, SEAS, that's and sustainability that's got climate data. They've got, weather data. They can link that with our data on asthma and look at exacerbations and outbreaks. So when I'm able to work with people like Emily and Meghan, they tell me, it'd be great if DataDirect could also do this. Sometimes it's new data needed. Sometimes it's more digested, clean views of the data we have. And sometimes it's just better functionality. Emily will show you, she has put in hours to make DataDirect work for her benefit, and downloading the data is pretty raw. And so she will tell us, like, what I'll be listening for is ways we, who build and support the tool can improve what you have to do to get closer to your analysis. Next slide. So think about mental health specific data not being just diagnoses and medications for mental health, referral for support services, but also a lot of questionnaires. We have PHQ-9, GAD. We have several other questionnaires that get at a patient's health and wellness, mentally and physically. Demographic data, we newly have the race category of Middle Eastern North African, which is our largest minority in Michigan, but it was never represented as one of the race categories. It's often other, sometimes Asian, sometimes Black, sometimes white. So that demographic is really important that we don't lose data about that population. Genomics, geolocation, and I mentioned wearables. Next slide. So 2 ways to get access to all these rich resources are either through a self-serve access, that's what Emily will talk about today, and maybe you code in SQL and you want direct access to the large relational database. Maybe you'll use DataDirect or Immerse. But if it is a really complex query that you maybe need scheduled to refresh on a given timeline, we have custom data extracts, and those we have if this is out of date, we have a $65 an hour recharge rate for that. And we can link disparate data sets for that as well. So that's just high level. The takeaway is to reach out to us, let us know what's not currently in the tools or in our offerings, what you'd like to see or what you'd like the tools to do in terms of better functionality. I'll turn it over to Emily.
Thanks, Erin. And thanks, Meghan, for introducing everything. I'm excited to be able to share with you all a few tips and tricks that I've learned as a user of DataDirect over the past couple of years. DataDirect is just such a fantastic resource, and I felt extremely fortunate to have access to the level of data that it offers. And one thing I just want to highlight before I jump into the tutorial is that I learned a lot of what I'm about to show you through the helpful user guide materials that the Data Office and Precision Health have on their sites, as well as their very knowledgeable teams who make themselves available for troubleshooting and consultations when you get stuck. So my hope is that today I can put what I've learned all into one place so that other researchers can get more familiar with the process of using DataDirect from a user's perspective. So I'm going to take you through the steps of using DataDirect in this kind of example project with that example project as a background. So I'll be highlighting a project that came from one of our incubator program participants, Mike Smith. Meghan's going to tell you a little bit about the incubator program near the end of the presentation. But Mike is a clinical associate professor in the College of Pharmacy and Michigan Medicine. And he was interested in quantifying medication burden in older adults who have been diagnosed with depression and centralized pain. Centralized pain is pain that's mediated by central nervous system dysfunction and is often prescribed antidepressants for treatment. And he wanted to test the hypothesis that having comorbid depression and centralized pain compared to just depression or just centralized pain may result in inappropriate medication burden for older adults, given the overlapping pathways of medications used to treat symptoms of each. So he came to us with this research question, and we were able to help him out by pulling the data from DataDirect and getting it ready for analysis. So here are some steps that we'll be covering today that should help you get started in your research with DataDirect. We'll talk about gaining access first, identifying your cohorts, identifying the output views or the variables that you're going to download, cleaning the data, and just a quick little bit about the analysis. So gaining access to DataDirect. First, I recommend taking a look at the DataDirect user guide. And throughout my slides here, I have some hyperlinks. You should be able to access those in the materials that we send out afterwards. So it should be pretty easy for you to kind of access these resources that I recommend. So this user guide also includes a page on the requirements for accessing. You might be asking, who can access DataDirect? And if you're watching this and affiliated with U of M, you're probably eligible one way or another. There are certain things that you'll need to do to gain access though, and you can check those requirements in the user guide. But I can talk about a couple of them here. Part of that is deciding which version of DataDirect is best for your project. One thing people may not realize that there's actually two versions of DataDirect. There's the Precision Health hosted version and the Michigan Medicine hosted version. They're both based on the same data, but the Precision Health version contains de-identified data and it's meant to be more broadly accessible. I'll go into some differences about the data itself to help you decide about which two you want to use, which of the two. But as a result of these differences, each has slightly different requirements for accessing. So just a couple things to highlight. You should definitely read more about it. Both versions are available to faculty, staff, and students. For the Precision Health version, faculty need to be members of Precision Health, and staff and students need to be sponsored by a faculty member who has a Precision Health membership. For the Michigan Medicine version, only students need faculty sponsorship. Otherwise, the staff and faculty can use it without any other kind of sponsorship. The Precision Health version is more broadly accessible. It requires only level 1 access, where the Michigan Medicine version, because it's got protected health information or PHI, requires level 2 access, as well as a Michigan Medicine core image computer and access to the Michigan Medicine VPN. So the reasons for the accessibility differences between the two versions lies in the differences in the nature of the data available in each. So this table is a helpful summary of from the user guide about the differences between the two. Much of the same data are available in both versions. The major difference is that Precision Health de-identifies the data, which takes some time to complete, and thus the data is only refreshed quarterly. This is why Precision Health DataDirect is more broadly accessible, though, and only requires a level 1 password to access. The Michigan Medicine version contains PHI, and it is refreshed nightly. The Precision Health data in DataDirect are also date shifted within patient. So this is something that helps with the de-identification. Importantly, the date shifting is all within patient and it's the same amount of time that's shifted. So patient A may have all their dates shifted by like 2 weeks, for example, and patient B may be shifted by 1 week. As the user, we don't know how much each patient's dates have been shifted, but the good thing is that the temporality is maintained within patient with the date shifting. So we can be confident that even if the dates have been shifted, the time that spans between the two within patient is accurate. Michigan Medicine dates are not shifted at all. So that's good to know if that is important for your project. And as of this presentation, one difference is that I found is that the Michigan Medicine DataDirect has wider data that are available. For example, the Precision Health version has data on medications that are filled at pharmacies, but the data are limited only to patients that participated in the Michigan Genomics Initiative and only to certain pharmacies. Whereas there was more comprehensive information on the Michigan Medicine version. And that's why we actually, for the project that I'm giving an example about today, decided to use the Michigan Medicine version. Another big difference between the two is how the data are stored. So for Precision Health, the data need to be stored on their secure enclave services, which is great, and that storage is provided. But that means that it's a little bit trickier to work with day to day. It's not as simple as having a file stored on your computer that you can load up into SPSS or R. You'll need to access through the virtual desktop machines and servers. Michigan Medicine data need to be stored on the researcher's own HIPAA compliant server. So if you have that set up, then it's easier to work with. And as a note, Dropbox Teams is approved for use with PHI. So that's one way that I've used Michigan Medicine data and was able to be in compliance. So once you know which version of DataDirect you're going to use, you connect to one of the VPNs, either the campus-wide VPN or the Michigan Medicine VPN. If you have access to both, I recommend just using the Michigan Medicine and level 2 credentials to log in, because that'll give you access to either Michigan Medicine or Precision Health DataDirect. So then you go to the DataDirect website, you log in, and it brings you to this pop-up here. So you can create a new query. If you see here, it says, help me choose the best option. So if you still don't really know which version of DataDirect you want to use, it'll ask you a couple questions to kind of help you decide. What we did was use Michigan Medicine DataDirect. It says Ph.I. And it brings you to this pop-up where you can create a blank query or select an existing query that you've already been working on. So create a blank query, and it brings you to this pop-up where you can name your project, create a description, and you see I haven't selected a Hume number or the IRB approved project number, and it gives me access to only to this cohort query mode. But this is awesome. This is something that I've loved as a user of DataDirect, is that it allows you to identify patients based on the criteria that you're interested in, even without having an approved IRB project. And it allows you to check the feasibility of your project even before going through all those other steps. If you do have IRB approval, you select it in this dropdown, you see it appear, and you're given access to PHI mode. What this does is allow you to actually download the data once you get to that step. You can also do recruitment using this tool and get, based on your approval with the IRB, gain contact information with different participants. So if that's something that you're interested in, you can go down that route. Click Save Changes, and it brings you to this main DataDirect screen. So just to orient you a little bit, on the left-hand side, we've got this cohort discovery tool, and it's got this panel with all these great views. We've got demographics that we can look into, encounters, comorbidities, diagnoses, etc. And this is how you define the cohort that you're interested in. Then under that, there's this output view selection. This is where you kind of do a search for the data that you want to be downloaded on the cohort. On the right, we have the cohort discovery results. So this tells you a little bit about the cohort as you add filters to it. So because we have no filters currently, you can see our initial count is 5.2 million patients, which is amazing. And in my background as a social psychologist, this is absolutely unheard of. So this is how this is such an incredible tool. And as we add filters, this final count of patients for your cohort will whittle down until you get the cohort that you are interested in studying. Then at the very bottom on the right is selected output views. As you choose the data that you want to download on your cohort, they'll add up here, and you will finally run the query when you're ready. So now you can start identifying your cohort of interests. And when I say cohort, I mean the group or groups of people that you want to include in your study. So here are some tips ahead of getting started. Plan ahead of time. That is something that I can't stress enough. Figure out what your cohort of interest is and what comparison cohorts make sense. Also think about how you want to analyze data from the cohorts. It's really important to go into this with your analysis in mind. So you're not thinking, oh man, I really should have pulled data from this comparison group so I can really make this statement about this other group. And then you have to go back and pull data all over again. Think about how you will define your cohorts in terms of the variables that are available too. So do you want to look at demographic information? Are you interested in predefined populations like people who are in the diabetes registry or their primary care patients? Are there any specific characteristics about the encounters that you want to restrict your cohort based on, like a range of dates or a specific visit location? And then are there any medications or procedures or diagnoses that must be present in your cohort? Or maybe you want to exclude people based on these kind of criteria. So take your time identifying ICD codes based on the literature, procedure codes, medication lists, and keep them all nice and organized. I do that in an Excel sheet, and that'll make your time in DataDirect a lot easier too. So in our example project, we wanted to identify patients who are Michigan Medicine primary care patients who are 18 and older, and who had one of our eligible ICD codes. So we started by looking in this populations tab. And here are all of these pre-configured populations that the DataDirect team has collected for you already. And we chose Michigan Medicine primary care patients. We did that because we knew then we would be able to follow them up over time. They're consistently going to get care at Michigan Medicine. We added this population. They come down here in the selected populations. And if we wanted to add other populations like COVID-19 patients or patients who have had a pregnancy with Michigan Medicine or who have genetic data, we could add them as well. So we click add. And that goes into the filters on the side. I'll show you where that goes in just a minute. Then I went to the Encounters tab, which is where you can narrow your cohort down based on age and date of service. You might think age is in the Demographics tab, but it makes more sense actually to have it here in the Encounters because your age changes with your encounters, right, over the years that you're visiting Michigan Medicine. So it's really narrowing it down based on the age at the date of service. So we selected dates of service between 2016 and basically this year for people from 18 years and up, because we wanted to look at a lifespan approach. So other demographics like gender, marital status, race, they're in the demographics tab. There's also a tab where you can select patients based on predetermined comorbidities, like depression is in this list. But I'd be careful using this right now. There's documentation here based on that kind of tells you how these comorbidities are created. For the depression one, when I included this as my criteria for finding patients, it actually pulled about 416,000 patients. But when I used the ICD codes that we pre-selected based on the literature for our project, we only got closer to 200,000. Which, you know, that those numbers are still huge, but there's a huge difference between those two. And that's because I found that there are actually bipolar ICD codes included in the depression comorbidity. And so that's not something that we're interested in for this project. So I recommend just doing your due diligence, checking these ICD codes to make sure that's something that you're interested in. Next, we went to the diagnoses tab. And this is where I spent a lot of my time for actually all the projects that I've done. And you can search for different conditions based on a few different lexicons. So there's ICD-9 and ICD-10. There's also MyChart diagnosis ID or in related diagnoses. I usually deselect these and just kind of focus on the ICD codes that I've collected. You can search the diagnosis code here in the search box, or you can search in the actual condition. Here's my example. This is really useful when you're first getting started, I'd say. So here I typed in the root code F32, which is the root for many depression-related codes. And you can see 12 results that have popped up that are all related. What's really cool about this is that on the right, you can see in yellow the number of times that code's been used in the system. And you actually see if you were to just input F32, that's used 0 times. So if you're thinking, oh, this is a depressive episode, I'll get a huge cohort based on this, it's actually not that prevalent. So you might want to consider using other codes. So you can select them all using these checked boxes, add selected, or what I do is I kind of just write these all down, copy and paste them into an Excel sheet, build them, check the literature, make sure it's relevant. And then I go to this import diagnoses code list and it opens this box and you can copy and paste, or you can upload a file with all of them. And then it gives you a list of them. You can validate it, making sure those codes are not spelled or typed incorrectly, that they're actually in the system. It gives you a list. You can deselect them if you think, oh, I don't want that anymore. Press OK, and then they all appear at the bottom of the screen. And you can still deselect them here if you want. This little checkbox is important. If you check it, it should come pre-checked when you add this. This means that you want to include all of these codes when you're creating your cohort. So people who have these codes can be included. If you uncheck this, it's saying that you want to exclude people if they have those diagnosis codes. So once you're ready, you can click Add at the bottom. and it goes over into this cohort discovery results panel on the right-hand side of the page. And this is what it looks like. So we've created a population of Michigan Medicine primary care patients. Here I did my depression and centralized pain cohort. So they have comorbid depression and centralized pain. So here are my centralized pain codes right here. And these bubbles, what it means basically, it's using and logic that someone is going to be part of your cohort if they meet all of these criteria. So they're a primary care patient and they have centralized pain, these codes, and they have a depression diagnosis, and they had an encounter in this range and they're 18 and above. So we've whittled down our cohort down to about 55,000 patients. Right next to each of these bubbles are icons like this one right here. This is a light switch. Basically, that will help you toggle on and off the filter. So if we turn that, we disable the filter, we can see how it impacts our cohort without actually having to use the X and get rid of it and then have to redefine it again. So we can toggle it on and off to see, oh, if we don't use the Michigan Medicine patients view, we actually get a lot more patients. That'll definitely impact the data that we get, but if that's something you're interested, you can use that to see how it impacts it. So going back, turning it back on, I just wanted to add a note about defining cohorts if you want to also look at comparison cohorts. So in our example project, I mentioned we wanted to compare 3 groups of people. So those with depression and no centralized pain, those with centralized pain and no depression, and those with both. So those with both are kind of our primary cohort. We want to see what the medication burden is for those folks, but it is more powerful in our analysis to be able to say compared to people who just have one of these conditions. So you can do this a couple of ways. You can make 3 separate cohorts, which means 3 separate queries, and then merging them after downloading them. Let me show you what that would look like. So I would make another cohort with depression, but no centralized pain. So you can see how that looks here. They have depression diagnosis codes, but excluding people with the centralized pain codes. And then we have a centralized pain with no depression. Here's their centralized pain codes, but excluding people with depression. Or you could download them all using OR logic, basically. So we have still primary care patients. Then we put all of our codes that we're interested in into one bubble here. And if they have any one of those codes, so centralized pain or depression, they'll be included. And then when we download the data, we kind of whittle them down. We say, we can use the codes there and say, you belong in this depression and centralized pain group or one of the other groups. So you use your script to kind of determine their cohort. The problem with this though, is you can see that's a huge cohort and it's actually too large to download. There's a 100,000 patient cap on being able to download these data, at least in the Michigan Medicine version of DataDirect. I think it's larger in Precision Health, but I'm not positive what that might be. So what I decided to do for this project is just go the 3 cohort route. Okay, so now we've identified our cohorts and we can search for the information that we want to be downloaded about those cohorts. And we do that in this output view selection. So an output view is basically a collection of related variables that also includes the necessary identifiers like patient ID or encounter ID to link it with the other output views that you're interested in. So I recommend taking time, just clicking through to look at the different views that are available and also looking at the data dictionaries documentation that's available online and is hyperlinked here. So first, for my project, we wanted to look at the diagnosis views. I'm not going to spend a ton of time here because it's going to be kind of project specific. But for us, in this diagnosis tab down here in this output view selection, each of these rectangles is a different output view. And they're all related to diagnoses. Here, you can kind of click this arrow and it'll tell you what's in each view. And down below is a preview of what you'll see in the data when you download it. So this is actually simulated data. So you're not actually seeing any real people here, but you do get an idea of what the data will be structured like. And here are all the list of variables that will come with your data. So you can see the ones with a plus sign are the ones that I've requested to be downloaded. So I'll have those in the data set that is downloaded. The ones with X's are going to be excluded. If I change my mind, I can just kind of click through these and they'll change from X's to pluses. Another thing to note is that some variables have this filter next to them, and that is helpful in that it funnels down, or it's a funnel or filter. It funnels down basically the data that will be included in your download. So for this, it's for the term name mapped. So that's basically the ICD codes. You might just want to have depression and centralized pain ICD codes in your data set, not every single diagnosis that the participants have ever had. And that really cuts down for file size, and you don't have as expansive a list. Some of you might be interested in the survey tab. This is where you're going to find questionnaires like PHQ-9. And then there are several other tabs you can see here: medications, labs, procedures, wearable data. Erin talked about, kind of the list of things that are available that are relevant for mental health. But if you are looking for something and you don't know exactly where it is, you can also search for it using this search all views, and that'll help you out. So there's a lot of great data here, an abundance of data really, but there's a lot of redundancy between views, and that's because the data might be pulled from different sources. But because of the redundancy, there also might be some differences, discrepancies between each of them. So for example, date of death might appear in multiple output views, but I found in some cases it's actually missing, and other cases it's available. Sometimes they're actually different. So you need to do some digging into the data to make sure you are confident in it, and you need to decide which view is most appropriate. So these are just some of my favorite views that you can kind of look at, but these are the ones that are my go-tos. So each output view that you select will appear at the bottom right of the DataDirect screen. So we have our output views. I selected 5, and it's underneath our cohort definition basically here. And once you're ready, you click Run Query. And you'll be asked to provide a password that you'll enter to open your data after it downloads. You'll be emailed after it's ready, and you'll be brought to a page like this. You create a file name. You will also need to read about and agree to the attestations about properly protecting and storing your data, and also specify where you're going to store it, and then you can download the file. So just a note, I think I already mentioned this, possibly the Dropbox Teams is a viable source as per the ITS Safe Computing site for a place to store your PHI data. So once your data are downloaded, you'll need to clean it and prepare it for analysis. And this part can get a little tricky depending on what you're using and how big your data are. So your data will be downloaded as an Excel workbook with 1 or more sheets for each of the output views you selected. So what you need to do, or at least what I've done, because I want to have all of my output views kind of merge together so I can do all of my analyses in one data frame, is you need to merge all of these views within patient. And this can be tricky as some output views contain multiple rows per patient, so they might have multiple encounters, and other views might contain multiple rows per participant or patient and encounter, so they might have multiple diagnoses per encounter. If you have multiple cohorts, you also need to append the different cohort files together. So in our example, we had 5 output views, 3 cohorts, and that results in 15 data frames to combine. So this can get a little tricky, especially if you have large data files and the sheets are actually split. So you might have 3 diagnoses sheets rather than just 1. So some data cleaning tips. As you're going, check your cohorts, make sure everyone meets the criteria you're specified in your query as you imagined it. Compare data from different output views like discrepant dates, and keep track of the number of observations and variables when you're merging and appending, especially when you have multiple ID variables like patient ID and encounter ID. And so I do all of my cleaning of DataDirect data using R. And here are just some useful bits of code that I've used and happy to kind of mention here. One thing, if you have very large data sets, I recommend once you download them from the Excel version to save them in FST format. That's a fast storage file. It compresses the data and it makes it a lot easier to open, a lot faster. And it takes up less space. Also, the package dplyr is fantastic if you haven't used it in R before. It's got a whole bunch of tools that are very useful. There are a couple of ways to format dates. And also, I plan on working on a script to share with this about flagging different medications or diagnoses. But I recommend really focusing in on the rows since there's so much data. Figuring out a way to focus on the rows that are necessary for your analysis. So it's kind of outside the scope of this webinar, but I've created a script for opening emerging DataDirect data. So we're not going to go into what we actually do, but if you are interested in looking at it and using it for your own research, you can find it on our GitHub page. And we hope to add some other scripts. So let me know if there's anything specific related to cleaning these data that you might want to see an example of, and I can potentially work on that and add it. So once our data are cleaned and analyzed, cleaned, and you have all the variables you need, it's time for analysis. And your analysis will, of course, be project specific. And as I mentioned earlier, perform all the steps within DataDirect with your final analysis in mind. So think about what question are you trying to answer? What kind of statement are you trying to make about your population of interests? What kind of comparisons are necessary? And if you need help with this analysis portion of the project, here's a few resources. This first one is a link to help deciding on the correct statistical test through UCLA. CSCAR is a fantastic resource. I've gone to them several times. If you have a question about anything stats related, even I think they do like coding help, programming help, that kind of thing. And they're very responsive and quick with their consultations. And you can also reach out to us at the Data and Design Corps, especially for mental health related research questions. We're very happy to help. So I know that this last part was a little shorter just because it's really project specific, but I hope the scripts that we have will be helpful for you. And in general, I hope having this user perspective has been helpful for those of you in using DataDirect. I'm grateful to have a chance to share the tips and tricks that I've collected while using it in my own work, and hope sharing it will encourage many of you to use it in your work too. With that, I will hand it back to Megan to wrap us up.
Thank you so much, Emily. That was excellent. I think that'll be extremely helpful for people. Before we open it up to questions, I see some questions coming in and we'll get to those in just a moment. But I did want to highlight two opportunities that our team offers to support your research with DataDirect. The first is a program that we offer called the Research Incubator. And this is this project, the project that Emily was using as an example was someone that we supported as part of this program. But the program offers access to our team's hands-on support for standalone research projects related to mental health. So all participants really need to bring is their own research ideas and their own content expertise. So you don't need to be a mental health expert to participate. And then we provide all of the hands-on staffing support that's needed for the projects. That includes all project management, data cleaning, statistical analysis, and support for dissemination. So you can think of us as your study team. And the program is open to all pre-tenure faculty, postdocs, and clinical fellows. Projects should be relevant to mental health, and they should take no more than a year to complete. So it's best for sort of smaller, medium-sized projects. And then they should use an existing data source. So it's a wonderful way to get support for a project that's using DataDirect or any other data source you're interested in. And there's no cost to participate. Our team's support is provided totally free. And we are currently accepting applications for that program. Those are due Friday, June 7th. So if that sounds like something you'd be interested in participating in, you can apply on our website. I will send around that link afterward. And next slide, please. If you don't have a full-on project that you want to propose that you need help with, but you need just, you have a quick question or just something that you need help with for something that you're already working on. We do also offer consultation for no cost. So whether it is something with DataDirect or another type of data that you're working with, you can request our help via our website or by emailing us, and we're always available and happy to help when we can. Next slide. So with that, this is the contact information for both of our teams. I know the data office is always available to help and answer questions and provide consultation. And Emily shared that that's how we have figured a lot of this out. But that is all we've planned to share today. So I think we'll open it up for questions. I see a few have already come in, so we can start digging into those. But if you have additional questions, you can use the Q&A function. We are happy to answer those. Just quickly to address Gabriel's comment about pasting the link to the GitHub, we will actually send everything out as a follow-up email in the next couple of days when everything is ready, so you have it all in one place. But the first question we can get to, I think this is one for Emily. This is from Meghan. Would pre-registration normally happen after cohort identification or selection, or after viewing the available outcomes?
That is a really good question. And that's something that we like to do in our core, is pre-register as much as possible. It's tricky with secondary data because pre-registration is meant to, for those of you who are not familiar with it, it's meant to kind of put your hypotheses or your analysis plan out there online usually, so that you can kind of avoid what people might call fishing expeditions, where you might look at 100 variables, one of them works, in your analysis, and that's what you publish on. So if you pre-register your hypothesis and analysis plan, you can often put that in your publication. So with secondary data, yeah, that does get tricky because what's to say you're not looking at all the data first and then finding it and then pre-registering. So I think that it's kind of open to you about at what point you want to do that. I recommend doing it after cohort identification, just to make sure that you have a population of interest. And what we have done, and also I think it would be helpful to look at the available outcomes too, because you know that you have this cohort, you know what you can find on these people to see if the analysis is actually possible. And then you can pre-register, what you will specify for your cohort, what data you have, what your analysis will look like. And then you can do all the cleaning after that. I actually would even make an argument that you can clean even before that, and you send in your pre-registration and then do your analysis, just because something might come up where you're thinking, oh, actually this variable isn't what I thought it was. I need something different. And then you're not kind of like stuck in a corner where you have to mention this pre-registration in your paper and it's not exactly what you followed. So I think as long as you're not running your analysis actually before pre-registering, I think that's at least how I kind of operate.
Awesome, thank you. The next question I think I'll hand to Erin. There's a question, sort of a bigger picture question about medical data being made available for research purposes. Do patients know that their data are being used this way? Is that communicated to patients? Do they consent for this? Are there ways to opt out? Do you want to answer that, Erin?
Yeah, I'm so grateful for this question. We do get asked this from time to time. Speaking strictly about the DataDirect tool, the cohort section that Emily demoed, where you're going to come up with a number, you're going to put in age and demographics, and that just gives you a number. That does not require IRB. That's just an aggregate summary you get. When you start downloading row level data about patients, that requires an IRB approval. The IRB may say, without names, addresses, phone numbers, that's considered low risk. We're going to give you a waiver of consent. And so your IRB will appear, as Emily showed you, in a dropdown when you log in. And when you select it, features within DataDirect are enabled or disabled so that you only get the minimum data that's been approved. If the IRB requires consent that says you can do for an initial period of finding eligible patients. You can use DataDirect or MyChartReview to find eligible patients, but then you need, and you have a waiver of informed consent for that, but you will need to consent them, and patients will need to choose yes or no. And so that's how the tool itself operates. Now, let me take a step back, because I think your question gets to something bigger. Can I come and get care at Michigan but opt out from any research? Not really. And so we're trying to, rather than hide that, make that explicitly open and something we're proud of to patients. So Dr. Runge has encouraged us to make sure that in the initial consent to treat and notice of privacy practices, the patients, including myself, my parents, my kids, that we sign when we come here, it says, we're a teaching hospital. You may be seen by a resident or med student. Your data, de-identified or limited, may be used in research. You come here to the university because you benefit from all the patients before you who have given their data, and now you'll give your data. And then we're going to have an actual campaign. We're working with communications to say, I'm a patient, I'm paying it forward, my data are used, they're not identified, I'm only contacted if there will be something higher risk that I'll get to say yes or no to. But we're creating a culture that really says your privacy and autonomy are our number one priority, and advancing your health and wellness are our second, and then continuing to help you, your family, your populations to come is also part of our critical mission. So it's a great question. Obviously, if you come here to the emergency room and you're like, I don't want to be in any research, we would never deny care. But if you're like, I want to establish long-term care here, but I don't want to be in any quality repository or research repository, we don't have a way to track that. So I'd love a follow-up conversation if you want to reach out to me, because we lose sleep over this all the time. How do we advance research, advance discoveries and cures, but still respect all of the patients who so generously allow us to look at their info? So I really thank you for submitting that question.
Thanks so much. A great answer. My audio is acting a little funky. Let's see. I think, Erin, maybe this is a question for you as well from Juan. What is going to happen when level 1 and level 2 passwords are merged for Michigan Medicine?
Juan, don't make me tell you the magic behind the scenes, because I don't know it, but the authentication is at the individual level. So now we have a combined password, but the system that you're logging into knows on the back end that you have level 2 credentials, even though the password isn't needed anymore. All the credentials that come with your role, peers training, whatever else is still there. All the credentials are the same. The password is now one, but on the back end, it either says, oh, you only have credentialing for level 1 systems or level 2. So that it doesn't change at all. I use DataDirect now with my combined password, and it's seamless. And then maybe, Megan, I'll look at Laura's. If she's having trouble logging into DataDirect using your level 2, you don't have to have membership. Laura, I wonder if you do need to be on the health system VPN if you're not. So it's check that, and if it doesn't work, send me an email. And Megan, I am happy if Emily may have a good IRB, but the secondary use IRB, when you're really just doing retrospective analysis, I could point you to sample IRBs, or if Emily has one, I'd be happy to, so you don't have to reinvent the wheel.
Yeah, we don't have any that are available as a template, but we have gone through the process multiple times. We'd be happy to help you via consultation if you're stuck, if you need help right now. But I think that's a great idea for something for us, Emily, to think about for the future, is developing some templates.
And Megan, I definitely have language for the methods section or resources and environment section that says at our institution, to tell a funder, we're ready to go if you give us the money. We have this secure tool, we have, access to rich data sources, things like that. So method section or acknowledgements in a paper, or that resources and environment section of a grant, just reach out to me. I'm happy to share that template language, if you will. I'm just reading the latest question. Is it possible to view the backend SQL query generated by DataDirect when a selection is made? Access to this query would be helpful. Oh, this is a great question. So when Emily was showing you all the boxes and clicks and drop downs in DataDirect, those choices were creating a SQL query on the back end that this attendee just referenced. The query is the huge 5 million patient relational database, and then it just brings you the answer. So I do, if you know, every DataDirect query you do has a query ID. And so if you have that query ID, you can email it to me and say, I'm curious in the SQL script that was generated from this DataDirect query, and we can share that with you if you want to aim it at a different database. If I answered that question correctly, I'm not sure if I did, but yeah, that's definitely possible to pull out the script that was created from your DataDirect selections.
Great. Well, we've got a couple more minutes, so if there are any other questions, feel free to add them to the Q&A. Well, it looks like things are slowing down. You can always contact either of our teams by email if other questions come up, but I think we can start to wrap up. So thank you all for joining and listening. Thank you to Emily and Erin for your wonderful presentations. We will send a follow-up email with this recording, a written tutorial that is on our knowledge base, a code example, information about the incubator program, anything else that we mentioned, we will send a one email with all of it in one place in the next couple of days. So we hope this was helpful. If you want to hear other sessions like this, if you have other topics to suggest, we would love to do more. So feel free to shoot us an email with your ideas. But with that, I think we can wrap up, and thank you everyone for being here.